Okay, guys, welcome back. So, in this unit, we're going to talk about breathing, right? And before we kind of dive into that, I do want to touch on some terminology that I think often gets conflated. Now, breathing is the overall umbrella term for that activity we do throughout every day, right? Moving air in and out of our lungs. However, there's two components to breathing. There is ventilation and then there is respiration. Respiration refers to the exchange of gas occurring at the alveolar capillary interface. So respiration equals gas exchange. Gas exchange. Okay? Ventilation is regarding the movement of air in and out of the lungs, right? So that's just air moving in, not necessarily exchanging. It's important that we understand this difference, right? Because while these terms are related, right, we can't have respiration if there's no air moving in and out of the airways or the lungs. But they are different though, and we find actually that you know respiration is quite often preserved even with significant changes to ventilation, right? I mean, that would make sense. Like if you've, exercised, your ability to exchange gases, right? We're able to keep blood pH pretty consistent even though ventilation changes, right? So they're related to each other, but they are distinctly different things. Now, we often see these terms conflated and might even be conflated in the book on occasion, and most certainly in the literature. But there are two distinct terms, ventilation and respiration. And ventilation is really all about flow. It might be a little joke here, and we're not, of course, regarding our the esteemed actress or character from commercials, but we're talking about FLW, flow, airflow. All right, so in terms of control of the airway smooth muscles, so it's important that we go over some basic terms. So we've got bronchoconstriction and bronchodilation. Bronchoconstriction would refer to the airways decreasing in size, and bronchodilation would refer to the airway diameter increasing in size. So you can give a little bit of appreciation for that. We'll draw a little airway. Here's our lumen. So in bronchoconstriction, we would see the airway get a little bit smaller by the smooth muscles, constricting. And then we've got our, bronchodilation, where the airway would get wider, right, to take in more air. So that would be bronchodilation. Our sympathetic nervous system, again, think of the saber-toothed tiger. If we're being chased by a saber-toothed tiger, it's probably advantageous for us to be able to take in more air and to exchange more gas more effectively. In order to do that, in order to move air in and out of our lungs a little bit faster, we want to open those airways up. So our sympathetic nervous system releases epinephrine, norepinephrine, which stimulates our beta-2 cells, or beta-2 receptors, which cause bronchodilation. Again, think of the saber-toothed tiger. What do we want to do if we're being chased by it? Parasympathetic, again, rest and digest. Probably don't need our airways super open. They're going to be more bronchoconstriction. Okay, so just remember that basic, differences between the two, parasympathetic versus sympathetic. Then we've got local factors, and probably the biggest one would be our mast cells, which are granulocytes that are located within the lung that are part of the immune inflammatory response, especially in response to infections and allergy and in particulate debris. They release a myriad of local factors that can affect the lung. Histamine, leukotrienes, which cause bronchoconstriction and congestion. That's why quite often if you have allergies, you get this chest congestion. It's a little bit more difficult to breathe just because there's more, the airway is a little bit more constricted. They also help stimulate mucus secretion as well. So they can cause, again, congestion, but in terms of airway control, the histamine, leukotrienes secreted by mast cells cause bronchoconstriction. And a lot of our drugs, therefore, your Benadryls, your Singulair, block histamine and leukotriene. That's why they're really effective for clearing chest congestion. And then we've got environmental factors, like we mentioned. Our lungs prefer warm, clean and humidified air. So if we breathe air that's a little bit, different than that, especially habitually, it's going to cause some, problems to our air. So again, we're really good at keeping airway temperature consistent, but if the air is really cold, sometimes it will cause a little bit of constriction to the lungs. That's why, running outside on a really cold day, sometimes it can just be a little bit tougher. Smoking, probably the worst thing you can possibly do to your body overall, and especially your lungs, will cause bronchoconstriction and will also stimulate your mast cells to release more of these factors too. And again, that's why smoking can be so dangerous and deleterious, because it's a repeated exposure essentially to smoke, right? So just kind of be aware of those things here. So again, we have our autonomic input, parasympathetic, bronchoconstriction, sympathetic, bronchodilation. Bronchodilation opens the airways, facilitated by beta 2 receptors, and then bronchoconstriction, parasympathetic. Then we'll get into the muscles of the ventilatory pump. Now, I think the muscles of ventilation are probably the coolest muscles in your entire body, and that's not just because I study these things as a researcher and just fascinated by them, but they're probably the only muscle that beats under complete involuntary control set by all these peripheral chemoreceptors that kind of affect our respiratory CPG. They work from the very first breath you take until the very last breath you take. But unlike the heart, which beats around the clock as well, you can take volitional control over it. So again, breathing, in many, not even just many, in pretty much every situation is involuntary. Your body is going to match breathing or ventilation to demand. But you can take volitional control, right? You can force yourself to breathe faster. You can hyperventilate. You can hypoventilate. You can even hold your breath, right? So there's no other muscle in the body that allows you to do that, right? That, again, has this involuntary control as well as a voluntary control. The cool thing about breathing, too, you practice the neural circuitry and the patterns and the CPGs in the third trimester of life. Like, we're really good at doing this. We've been practicing it for a long time. Key thing that I want to mention, your muscles of ventilation work against airway resistance, which is really predicated on the diameter of the airways. So if our airways are a little bit smaller, the resistance is going to be a little bit higher. And if they're a little bit more dilated, resistance is going to be a little bit lower. And they also work against elastic recoil forces of the lung and chest wall. Remembering again that it's a balance between the two, right? The lungs tend to want to pull in due to their surface tension. They want to collapse on themselves. And they also have these elastin particles. And we'll get more into that later on when we get into the specifics of breathing. Now, for inspiration, which is an active process, the majority of that effort is produced by the diaphragm, or the thoracic diaphragm, which, depending on the book you may read, 75 to 80% of the inspiratory effort. The diaphragm, again, is stimulated by the phrenic nerve, which comes from nerve roots C3 through C5, primarily contributions from C4. Now, we also have quote-unquote accessory muscles, so muscles that account for the remaining 15-20%. I really want to kind of challenge the fact that these are accessory muscles, because they are always sort of active, especially your scalenes and sort of clitomastoid. These muscles operate essentially by their reverse action, because they attach to the chest wall, specifically the upper chest. And we find that they're on even during quiet breathing, and that's actually pretty important, because these are what help elevate the ribs during breathing. And we'll talk about why that's important later on. Expiration is primarily passive, and it's due to elastic recoil forces in the chest wall and the lungs. And we'll talk about how this kind of works and how this force coupling changes. So expiration is passive. We don't spend any energy to do it. Inspiration is active, and we use our diaphragm primarily to accomplish it, though we do have other muscles that help kick in. Now, forced efforts, of inspiration or expiration, a classic example of expiration being a forced effort would be coughing, or is hyperventilating, or breathing faster during exercise. Now, obviously, the abdomen, the abdominals, and intercostals, and other muscles will kick in, and these force relationships will be a little bit different. But at rest, the diaphragm's primarily the muscle involved here for inspiration, and again, expiration being passive. And again, I really think this muscle is pretty cool, man. Again, just a little bit of a reference. The total compliance, right, or static compliance of the lungs is roughly about 2 to 3 centimeters of water, which is a unit that we reference in, or is a unit that we reference pressures in the lungs. So it's these centimeters of water. The total force output of the diaphragm is, for most people, it's around 100 centimeters of water. To expand the lungs and to bring in a normal tidal volume, we only typically have to bring in generate about 5 to 10 centimeters of water, because static compliance 2 to 3 roughly per liter, and with a tidal volume at rest being about 500 liters for most individuals, it corresponds only about 5 to 10. So we only work at maybe like a fraction of the percentage of our peak force producing capabilities of our muscles. Again, not only do we have an incredible reserve in terms of lung volumes, the force generation and pressure generation capabilities of our respiratory muscles are incredible. We've got an incredible reserve. And this is all accomplished by influencing changes in the pleura, which influence changes in the lung. Now, we're going to go over some basic pressures. We'll go over this later on in more detail. But the 4 pressures that are associated with ventilation, right? So atmospheric pressure, which is the pressure in the outside ambient air, which you guys remember from physics, is 760 millimeters of mercury. So we're going to use millimeters of mercury for this part here. Or we can remember 1 atmosphere, but it's probably going to be better to remember these units here, millimeters of mercury. Intrapulmonary pressure, or alveolar pressure, which is what will vary with ventilation as we breathe in. At rest, it's at atmospheric, so that point between inspiration and expiration. The lungs are open to the atmosphere, so the pressures in them are at rest. Its static conditions are 0 millimeters of mercury relative to atmospheric. So these are in relation to atmospheric. We do this instead of writing out the full 3 units, 760, just to keep things simplified. So if you see 0 in some of these units or some of these examples, it's in reference to atmospheric, meaning that at rest, the pressure in the alveoli or the airways is 760. It's equal to atmospheric. Okay. Now during inspiration, right, the pressure in the alveoli become lower than atmospheric, and that draws air in. Remembering that rule, pressure moves from high to low. So if we decrease the pressure in the alveoli and the pulmonary or interpulmonary pressure, it will allow air to enter into the lungs by creating a pressure gradient. During expiration, the pressure in the airways and the alveoli become greater than atmospheric, and that helps air exit the lungs or out. Okay, and again, because pressure goes from high to low, so all about changing those pressures. Intrapleural pressure is always less than intraalveolar pressure. Again, that's that pressure in that potential space, and at rest, it's -4 relative to atmospheric. That's important because it allows our lungs to stay inflated. Okay, it's this closed off environment. And then we have transpulmonary pressure, which is the difference in intrapleural pressure relative to intrapulmonary pressure. And I think this image we'll show on the next slide will help kind of elucidate this, right? So again, we've got these 3 pressures or 3 forces kind of in balance with each other. Again, we've got our lung here, which has this elastic recoil, the surface tension that generally wants to pull the lung in. The lung wants to move in this direction, right? Our chest wall, which is represented by the kind of orange color, tends to want to pull out towards the spine. Okay? The balance of these forces creates this negative pressure in the pleural space. This -4. These forces are at equilibrium, and the force is lung and chest wall are balanced, creating this negative pressure in the pleural space, which helps keeps the lungs inflated. And again, this is all relative to atmospheric. So again, the lung is at 0 relative to atmosphere, but that's really 760 because atmospheric is 760. The pleural sac is at 756, but that's -4 relative to atmospheric. And basically the way inspiration operates is by changing the volume in the pleural space. And we'll go over that in a second. So the mechanics of breathing during inspiration. So in the relaxed state, the diaphragm is dome-shaped. As it contracts, it descends. And when it does, it increases the thoracic volume. It starts to expand and open up the chest, as well as the accessory muscles, help elevate the top ribs. When this happens, this increases thoracic volume and therefore increases intrapleural volume. You guys remember Boyle's law, pressure and the inverse to volume. If volume increases, pressure must decrease, especially in a closed chamber. So this increase in thoracic volume as the chest wall moves away increases the volume in this potential space. So this moves out. This increases in size. Make a plus sign. So volume increases, and then thus pressure decreases. Well, if pressure further decreases in the pleural space, it will allow the lungs to inflate, right? Because there's even less pressure pushing against them. So by expanding the thoracic volume, it decreases the pressure in the pleural space by increasing its volume. So by expanding the chest, we expand the volume in the pleural space, further decrease its pressure in the pleural space, which allows the lungs to increase their volume, which causes their pressure to decrease, and that allows air to flow in, right? It's all by dictating these changes in the thoracic wall, which influence then the intrapleural space, which then allow the lungs to further expand and increase their volume, which decreases their pressure and allows air to flow in. And again, if pressure in the lungs or the alveoli is lower than atmospheric, it will draw air into the lungs from the atmosphere. Pressure goes from high to low. Inspiration ends, therefore, when thoracic volume ceases to increase, no further reduction in pleural pressure or intrapulmonary pressure, and then there's no more air coming into the lungs. And again, just as an example of that here. Again, as the diaphragm contracts, it descends and flattens. The dimensions of the thoracic space increase. It increases the space, the volume in the pleural sac, decreases its pressure even further, which causes an increase in volume in the lung, and thus decreasing the pressure in the lung, allowing air to flow in from the atmosphere into the lung. And mechanics of expiration, again, it's a passive process, remembering that as we breathe in, right, our lungs expand, and our lungs contain those elastin particles. As elastin, or like if you think of a coil, winds up, it has a tendency to want to pull back. The same kind of thing happens. As we breathe in, we wind up all that elastic potential in the lungs. And remembering at rest, these forces are balanced. The lung and the chest wall are at balance. As we move the chest wall further to where it wants to go, again, it wants to pull out. As we move it further towards where it wants to go, it decreases its ability to pull out because we're moving towards its destination. However, the potential energy in the lungs increases. So at the end of expiration, the force coupling favors the elastic recoil pressures in the lung, causing him to recoil. So basically what happens is as we expand and fill the lungs, the outward pull of the chest wall decreases, whereas the inward pull of the lungs increases, and it causes the lungs to want to recoil back. As well as we have pressure changes in the airway due to this, forcing air out. We'll go over more of this later on, but I want to go over the mechanics of the chest wall because this really dictates some of the pressure changes we eventually see in the airway. So as the diaphragm relaxes, it moves back up into its resting state, that dome state, and we have air flowing out of the lungs. So again, it's all about changes in pressure, which are dictated by changes in the thoracic wall, influencing changes in the pleural space, and eventually changes in the lung. And again, in terms of the general movement pattern, because this is geared for physical therapists, we've got two general patterns we observe in the lungs. We have our bucket handle displacements, okay, which you have here, identified here, which are more of this, almost a superior and lateral or frontal plane movement, which we see more pronounced in the lower ribs. We see this, bucket handle morphology or pattern. In our upper ribs, we see more of what we call a pump handle movement, where it's more of an anterior, so they're moving from the posterior ribs, they're moving this way. They're moving superiorly and anteriorly, right? So you taken together, the general pattern or direction or displacement of the chest during breathing, during inspiration, is a superior, lateral, and anterior displacement. And I mention this is because while we see the bucket handle more in the lower ribs and we see the pump handle more in the upper ribs, we tend to see actually all of those movements in the entire region of the chest wall. They're just more pronounced in these typical regions. Again, movements triplanar, right? There's going to be a frontal plane, a sagittal plane, and a transverse plane to every movement. But some of those planes can be a little bit more pronounced than others. So again, bucket handle, it's that lateral and superior displacement. You typically see that more in the lower ribs, more pronounced there. And then we have the pump handle, which is more of that posterior to anterior and superior displacement, which we see more in the upper rib cage. And that's really predicated especially by those we quote unquote accessory muscles, but again, which aren't really accessory because they're always sort of working. Just to kind of wrap up here, which I think is kind of cool, we've got a video of what a thoracic diaphragm looks like when it contracts. I just think this is kind of neat. So I'll play a little clip here. The best one here is on the right. So as we can see, so this is an example of a diaphragm under ultrasound. So on the top here, we have the skin. This is the skin. This is the diaphragm, rib cage, pleural space. So I'll play it again. And you can see as the person breathes in, the diaphragm moves and descends. So this area here, we see that red mark, this would be the abdominal contents or the lower part of the thoracic cavity. And as a person breathes in and inflates, you can see the lungs descend, the diaphragm thicken as it peels away from the rib cage. Pretty neat. Cool. So with that, we'll end here, and we'll get into the pressures associated with ventilation more specifically in the next unit.